Yes, I'm going to unmute myself. Hey, everyone. Uh, I'm going to screen share. Sorry, dumb thought. Dumb thought snuck into my head right as I started this, and it made me laugh. Yeah. Anyways, okay, let's finish. I think this week we got to be finishing 8 out of the 10 patient scenarios, and this will be the 6th one from the previous weeks. I haven't. Oh shoot, yeah, I could make the last 2 this week. We're finishing up with them. So yeah. Well, here's the psychiatric emergency that we had, I think, in the first week that we were doing these, but I want to make a video of it in case you haven't done it yet. So let's look it over. You've got a mental health patient cleared in, so the scene is safe. On a suicidal patient, you still have to ask for it. And then when you get on scenes like this, still watch out for them, because you never know. I had a guy who was caught huffing in a Walmart bathroom. Great big fella. And when we walked in and the officers said, yes, he's safe and he's calm. And he had a couple empty canisters of computer duster next to him. And when he stood up, the guy was a few inches taller than me. Great big fella. And when he walked out of the Walmart bathroom with me, I was right next to him. There was a cop in the bathroom with him and my partner. He bent over to pick up another empty canister because he'd gone through like 4 of them. He tried to huff it like right in front of us. Like I'm standing right next to him. So I grabbed him, and then I realized that I just grabbed a hold of this great big fella and didn't have a good plan of after I got a hold of him. So thankfully there were 3 of us and he didn't put up much of a fight. So he tried to huff it. He got it right up to his mouth, and I grabbed the can out of him. I'm like, dude, what is wrong with you? So keep your eyes open, keep your senses alert. And the biggest lesson that I learned with mental health patients, any patient, but especially mental health, is that your job is not to be nice, it's not to be mean, it's to be respectful. But it's to respectfully provide very strong direction to these people. Because these are people, and it can be anybody. You can have the happiest, healthiest son of a gun out there. Something happens in their life, something changes, some condition changes, and they can end up really misleading themselves and going into very dangerous, very life-threatening. I've gone on plenty of suicides in the last 10 years of doing this job, that people will kill themselves. People will kill other people. You never know. So provide them with direction. They haven't, and that's the biggest thing. Like when we talk about airway, breathing, circulation emergencies, in my class, I've always talked about how, one of the reasons why we check alertness level and why I always harp on checking behaviors that changes to people's level of consciousness are incredible life threats. That's why it's early on in the assessment, because that assessment looks for apparent life threats. Well, if people are confused, incoherent, if they're altered, they're not going to do good things for themselves. They're going to take themselves in bad directions, right? Even intoxicated people, being heavily intoxicated is an apparent life threat. I've gone in drunk people who walk out into traffic. That's why when I get some drunk person who's heavily intoxicated and they don't want to go to the hospital and they get mad about it, they try to defend their right to drink. And it's like, yeah, no one's taking your right to drink away. We're just taking your right to do stupid stuff after you drink away, like run into traffic, like try to drive a car where you're going to kill yourself or somebody else. So we're not trying to be overly dramatic on these things, but this is a person, like some drunk person. This is a person who has taken, he's cut himself with a pocket knife. So he's actually gone blade to skin. So he's showing you that he's not directing himself well. And, you could get other people that would argue, well, it's a superficial cut. Well, it doesn't matter if it's a superficial cut or not. They're putting a blade to their skin. They're still endangering themselves. This isn't a healthy thing. They're not steaming broccoli. Okay. They're putting blade to skin. This is very bad. This is very dangerous. And I usually don't talk too much to these folks. I'm not a counselor. I'm not a therapist. I don't know how to do that in a healthy way. But doesn't mean I can't be honest and direct with them. And I'll tell people to be very careful. I understand that people might cut to feel, right? I get that. But they don't know what they're cutting. If you cut a nerve, you might not get that nerve back, right? If you slice a nerve and that nerve supplies movement or sensation to a part of your body beyond where you've cut it, you might never get that feeling back. Also, there are blood vessels that people can cut and not realize they're cutting them. And for the untrained, uninitiated person, and I can say this from experience, the first time you see a copious amount of blood, it can catch you off guard, and it can really, it can stop you. You know, just the sight of it, let alone pumping out of someone's own hand or own wrist, right? So these people need strong, respectful direction. Sorry, that's a big, long tirade, but a lot of people don't. I've had partners that just let them kill themselves. I mean, these are paramedics and EMTs that I think this kind of thing threatens them. It's very threatening to them, and they don't know how to approach it. They feel a certain way about it, and they don't know a healthy way to approach it. It's okay to be angry at people who hurt themselves. It's totally fine. It's totally healthy to be angry, but we have to keep in mind that we have a job to do, and that's to help this person. So the patient's threatening suicide, threatening to cut himself with a pocket knife. Airway open, yep. Breathing is okay, circulation is okay. What does that mean? I didn't write this, so I would say circulation. If you ask for circulation, I'd say strong, regular radial pulses. I don't know. I'm not a grammar expert. Skin is pink, warm, dry. Regarding the punctuation between these. Now, bleeding is controlled. If circulation is okay, that's what it would, and that's the big thing we're worried about now is the circulation. Okay, that doesn't tell you anything. If you write in your chart with me, if you were ever my student in the future, and you write that something is okay, I'm gonna make you rewrite it. And if you put okay again, I'm gonna make you rewrite that. It's not okay. You have to describe it. Okay. I just said okay. Breathing, non-labored. Airway open, that's pretty good. Signs, the patient's feeling depressed, they're feeling worthless, desire to end it all. It's pretty common thoughts and feelings from people who are feeling this way. Allergy, lots of foods. Okay, so if anyone's allergic, if you get a patient who's allergic to everything, food or medication, yeah, I think it might be a very sensitive person. That's the respectful way we say it. They take Effexor, okay, that's an antidepressant. Chronic depression, so it's been going on for a long time, chronically depressed. And how old is this patient? 26-year-old male, chronically depressed, yeah, that's tough. And cutting, if people who don't have a good concept of what depression actually is, I think it's just people being sad, but it's a whole lot more than that. It's way more personal than that. It's a real deal. Again, these people will end their lives. And so I've heard well-meaning, well-intentioned people say something like, you know, your suicide's a permanent solution to a temporary problem. It's like, do you honestly think that's going to help? Do you think that the patient hearing that is going to be like, you know what? I never thought of it like that. I never thought of me trying to end my life like that. And you know what? Since you said it, I'm all okay. That just fixed everything. Wow. Thank you for putting into perspective for me. No. The patient who hears that thinks this guy or girl, whoever says it to him, doesn't get it and doesn't care. That's what that says. That's what that communicates. Doesn't get it, doesn't care. Hopefully the person is understanding enough to know that they mean well. I think they do. When I've heard that those times, they truly do mean well. They want to help, they just can't and don't know how. All right. Last oral intake, no food since sometime yesterday. That's not uncommon. And feeling like he wanted to die, cut himself shallow with a pocket knife and posted photos on Instagram. So this right here, again, I didn't write this. I can think of dozens of calls I've been on similar to this. And what this tells me, and again, I'm not this person, I don't know how they feel, but hearing this when we talk to people and we can empathize with them, shallow cuts means they're feeling the pain, and it's almost like they want to do something. They have this depression, they have this pain, they have this internal conflict, whatever they're dealing with, and they just want to do something about it. They don't know what to do. They feel powerless. So what do they have power over? They have power over what they do to themselves, right? And so they cut. But I truly don't believe that most of these people actually want to end their lives. I believe that most of these people want to end their pain. They don't want to end their lives. They want to end their pain. They want to end their helplessness and hopelessness and feelings of worthlessness. That's what they want to end, but they don't know how to. They don't know how to. They don't know how to resolve it in their lives. So they're just going to end the life. But cutting shallow shows that they don't really want to die. I don't think. But again, I'm not an expert on this stuff. And then they post the photos to Instagram. So they want attention for these photos. They want attention for how they're feeling. They want someone to help them. They just don't know a healthy way to do it. That's not a healthy way to ask for attention. When I want attention from someone, I call them up and say, I'd like attention from you right now. I've done that with friends. I'd like attention from you, and my mom, and my dad, and my dogs. But these poor folks, they struggle. Yeah. See, heart rate 114. Blood pressure 92 or 46. Okay, so right now, reading these vitals, 114, that's an elevated heart rate. And a blood pressure 92 over 46, that's hypotensive. So this is starting to make me question whether or not the person writing this really thought it through, because that would make me think that the patient's actually been bleeding. I'd be very worried about other bleeding elsewhere, because that's not good. Or did they take something? I would be thinking they may have taken some kind of drug that would decrease their blood pressure, some kind of depressant. Pulse ox is looking okay. End tidal, that's fine. Sinus tach, yeah. Sugar's fine. Temp's fine. Let's see. No, you need to transfer this patient. Yeah, okay. Well, the scenario isn't exactly following itself very well. If I had this patient who self-harmed, who actually self-harmed, and they looked this good over here in their general impression, or in your general primary assessment, but then you check their vitals and they've got abnormal vitals like this, I'd be highly suspicious. I'd be very concerned that there was something else going on. I would expose this patient. Most patients I don't expose, but this patient I would. Okay, you got a shallow cut on your wrist or on your arm. Yeah, where's this other bleeding coming from? I need to see. And so I would expose the chest. I'd expose all the way to the groin, because people have cut their groins before. I'd look for the other source of injury that could cause, I'd want to know what's causing the hypotension and the tachycardia, because that's showing shock. It's just my opinion. If this person is yeah, you don't need to go overboard. Everyone wants to be like, well, if they had Lance Armstrong, then maybe they're resting blood pressure. Okay, you're not going on Lance Armstrong. You're not. Just stop with that. Stop. In the real world, you're not dealing with elite athletes every day. So, plus they won't have to have a resting heart rate of 114. You share. All right. Sorry, getting a little ramped up. Okay, so let's write this. So we'll just call ourselves EMS. Oh, actually, let's rename our SOAP narrative. Mental health. Okay, EMS is dispatched to a home for a possible suicide attempt. Done. Chief complaint, patient states he's feeling depressed, worthless, and wants to end it all. We can put that in parentheses. No. Oh my God, we can quote it. Did I show you guys the other day? I misspelled my own name. Like, no, legit. We got these new N95 masks at work, and we had to write our name on this little box they gave us, and I forgot the I in my name. So it's kind of week we're having. We're having a great week. Look at my haircut. My friend cut my hair yesterday. Oh, it's so much better. And it's nice out. Sorry. All right. This video is going on forever. Patient states he's feeling depressed, worthless, and wants to end it all. See how we can quote that, not parentheses it? Because he said it. We heard him say it. And that's what was in the chart, or in the scenario. Patient states he cut his wrist with a pocket knife today. Okay. So that's his chief complaint. Do I have to hyphenate the pocket knife? Pocket knife. It is important to describe what kind of tool this patient used to cut themselves with. And seriously, if they used a katana, like I've had partners go on katana calls, those might be a little more sharp and a little more deadly than a pocket knife. Onset, patient states he's been depressed for several years, and that he's had several, hang on. So years, patient states he cut, now let's restart that. Patient states he cut his wrist about 20 minutes ago. How about that? Say 30 minutes ago. Doesn't matter. 30 minutes ago. And posted the pictures on instead. I'll just say online. Provokes. Now here's where we're going to get specific about these types of calls. I'm not going to dig. It's not that I don't want to help this person. It's that I'm not trained in how to. Yeah, I can listen. Yeah, I can have my own intuition that could tell me what is a good way to approach these people or similar patients, but I'm not trained. I'm not a doctor. I'm not a psychologist. I'm not a therapist. I'm not a social worker. I have not been formally trained in how to do this. Now, yes, you can be a good friend. You can be a good, non-judgmental, open ear. But if you start digging in people's lives, if you start digging in the origins of their depression, you're responsible for what you dig up. You really are. And you're only going to have this patient for half an hour, not even. It's none of your business to dig this stuff up. And I've cut off students who try to ask too many questions. Now, if a patient starts to talk on their own, I'll listen to them. I don't tell them to stop talking. It's just I'm not going to dig. Okay, so I'm not going to say, well, what makes your depression worse? Okay. And tell me about those issues that you've had for a long time that I have absolutely no business knowing about. I had a student, a dumb student. This guy was an idiot. This guy was super self-absorbed. He couldn't take feedback. He's the one that used to clear his teeth at me when I could tell I triggered him, giving him feedback, and I wasn't trying to. I was trying to get him to learn. And he clears his teeth at me. Like, he's struck a nerve right there. He actually asked a teenage girl if her uncle was the source of her PTSD. This dipshit student asked this. I couldn't believe it. And I'd already told him to stop talking because he'd already asked too much. And his dumb ego just kept him right going. Well, is your uncle a source of your PTSD? I'm like, stop talking. Dude, you're done. Stop. And I looked at the girl. I said, kiddo, it's okay. You don't have to answer that. I understand you have PTSD. You don't have to answer that. Let's just get to the hospital. And she said, oh, no, he's not a source of my PTSD, but my therapist told me that I shouldn't be around him. And I'm thinking, yeah, probably because your therapist knows that he's been molesting you or whatever the heck the guy's doing. And then my dumb student opened his dumb mouth again and said, is that the kind of thing you talk about in therapy? And I looked at him and said, stop it. You're done. Nowadays, I would have kicked him out. I don't give a flying hoot. I would have just kicked him out. I would have said, pull over and leave my ambulance right now. Find yourself a ride home. Oh my God. After the call, we talked about that call. And he told me that despite making a few mistakes, he thought it was the best call he'd run with me so far. I couldn't. He was so delusional, so self-absorbed and so delusional. It was unreal. So don't dig. You're not trained on how to dig. Don't dig. If they talk, listen, but don't ask. Don't ask. See, I had to clear my neck. So you saw that I got triggered because I had to. That's what I did to my student after he's doing that. Giving him feedback. I was like, and I told him, I don't think you could have run that call any worse if you tried. I have major concerns with how you're doing this. And then he cleared his teeth at me, and then he denied that he asked that question. That's not what I meant to. It's not what I was trying. I'm like, no, dude, you're done. You're done. What an idiot. If he's watching this, you should agree with me. If he's watching this, I would give him the benefit of the doubt that, yeah, he was inexperienced and he didn't really know what he was doing. But he should say, yep, that was a dumbass move on my part. And I would never ask that again. So if you're watching this and you see this and you're like, oh, that was me. Yeah, I was a complete idiot. Yeah, absolutely. Yeah. Change. Sorry, guys. Okay, let's get back to this. Provokes. We're not going to ask what makes your depression worse. Does anything make your cut worse? Yeah, touching it. You don't need to ask provokes. Quality. What does your cut feel like? Doesn't matter. We're not asking that. Radiates. This question doesn't apply in severity. Come on, man. It hurts. I'm not going to ask him obvious, stupid questions. On a scale of 1 to 10, where you sliced your arm, how would you rate that pain? It doesn't matter. You don't need to. No. So delete all that. I have a hard time with people being bullies, and I have a hard time with people being self-absorbed and egotistical. And so I get a little ramped up when I see it. And these calls tend to bring it out in people. They really do. Suicide is just a permanent solution to a temporary problem. That ought to fix them. Yeah, I'm really wise. That's a lot of wisdom. It just blew my mind with all the wisdom. And I haven't, it's not just once I've heard that. I've heard that many, many times. It's unreal. It's unreal. All right, anyways. Events leading, we already talked about that. He's been feeling depressed for a long time. Actually, I might say that. Yeah, events. Patient. Depressed for several years. That kind of goes in medical history, but we'll cross that bridge. Okay, so there we go. Secondary complaints, we've already talked about them. There's no secondary complaints. Pertinent negatives. Now, usually I would say, okay, do you have any kind? How's your head feel? How's your breathing doing? How's your chest doing? I'm not going to ask that on this patient. Maybe once I get his vitals back, I would. But again, these folks, I'm really limiting how much I ask them. They're going through a rough time. They don't need some jerk like me coming in thinking I know too much and asking them all these questions. They need me to be respectful, to provide them direction, to understand what they're feeling, and to move them to the hospital so they can get going in this. They don't need me digging. The doc's going to ask them all this stuff anyways. So I'm not going to write any of this stuff. Ooh, no, not that. Again, this is just my approach. You can see other people's approach, and they'll tell you that I'm a complete moron and I don't know what I'm doing, but this is my approach that I've developed, and it's worked fairly well. Allergies, no known diagnosed allergies, medications, oh no, he says allergic to everything, but that usually means nothing. It means I drank a cup of coffee yesterday and now my tummy hurts and I blame it on the coffee. I'm allergic to cold coffee. Blah. Okay. Medical history, depression, and probably previous self-harm and suicide attempts. There's a big difference between a suicide attempt and actual self-harm. And a lot of these folks have done both. Again, I'm not going to ask. You'll be like, well, how did you try to kill yourself in the past? No. Are you in the past? No, you're not. Unless evidence of the past is coming up now, no. Deal with the now. It doesn't matter. That's just for entertainment. And if you ask that and you try to claim that it's not for entertainment, you're full of shit. Food, drink, I don't care. I don't care unless it's alcohol. So I might say last oral intake, last intake, patient, I might put that up here actually. Patient denies alcohol today. That's a good pertinent negative. I've forgotten that pertinent negative on the last ones. That's a good one. I don't ask everybody it. I just ask certain. All right, age, gender. We'll fly through this. 26. Patient is a 26-year-old male found sitting calmly inside his home with PD on scene prior to arrival. Scene. With PD and let's say families there on scene prior to arrival. Patient is AO times 4 with calm but depressed behavior. Patient is cooperative with this. We'll say that. Airway's open. We don't need to say it if he's breathing okay. Breathing is non-labored with no abnormal sounds. I'm going to listen to this guy's lung sounds. Lung sounds are clear and equal. Why? Because he could have shanked himself or shivved himself in the chest. You'd never know. Pulses. Apparently he's got strong pulses, but whatever. Strong, regular, radial pulses. You know what? Screw this. Pulses. Screw this. Hang on a second. Whoop, not stop share. Pause recording. Yeah, I've just made an executive paramedic decision. We're changing these vitals to match. Because if he's calling them shallow cuts, his skin and circulation look good, I'm going to make it reflect in here. Maybe he's a little tachycardic because he's anxious, he's nervous, he's scared, he's upset. I'll give you that. But he's not going to, if he's hypotensive, there needs to be a cause of that. You give us a cause. Yeah, don't, yeah. So, new share. Yeah, strong, regular radial pulses. Skin is pink, warm, and dry because he's not hypotensive. Trauma, noted superficial self-inflicted lacerations to patient's left wrist. Bleeding is controlled. Whoop. Covered with dressing. Notes bleeding is controlled. Patient, no other trauma noted. Okay, so there we go. We have that. And we're going to combine that. Combine that. Take this away. And there's a pretty darn patient. Oh, there's a pretty darn good word can handle that. Head, eyes, ears, nose. Now we want to go through this. Pearl. I'm also going to say no trauma, right? Because this person's hurt himself. We want to check. We need to check his body for other signs of trauma. Right? No trauma. Chest. No trauma. To anterior or posterior. Look, now someone's not going to stab themselves in the back. They can't, but I'd still make sure that they didn't do anything to the back of their chest or to their anterior chest. Abdomen, soft, non-tender, times 4. I'm not palpating this person's. You know what? I'm not doing it. I'm not doing it. No trauma. I'm not palpating this person's tummy ones. I'm not doing it. They don't need you to. Extremities, wound to left wrist is covered with bandage. No other ZMS times 4. That's okay. That's I'm not going to check cap refill. Screw. Hey, look at this. Look at the guy's got a 114/76. Not hypotensive. 102. Respir's a 16. %. I think what they were trying to go for is trying to show you that they've suffered some blood loss with those early vitals, but it would need to be reflected in the circulation. If someone's lost that much blood to where they're hypotensive, they're going to look pale and clammy, and it's going to be more than a superficial cut. So that didn't match up. So we're not going to go with it. It's part of becoming a paramedic EMT is that you guys don't just, you're not passive. Be submissive. I've talked about the difference between submission and passivity. We don't want passive. I'm submissive, right? If I'm working under someone's direction, I acknowledge that. I submit to their direction. However, I'm not passive to it. If they're like, oh, I want you to go do this impossible, dumb task, I'm not be like, oh, okay, yeah, I'll do whatever you want. I'm going to say, okay, if you want me to do this task, here's what I'm going to need from you in order for me to do it. That's submissive. I acknowledge that you want me to do a task. Here's what I need from you in order to do this task that you've requested me to do under their direction. And if they said, well, no, I'm not going to give you what you need to do the job that I'm expecting you to do, the passive person says, hey, no big deal, no problem. I'm ready to go. Whatever you want. The submissive person says, okay, well, that's not going to work for me. I'm going to need those things. And if you're not willing or can't provide them for me, then I'm not going to do what you want me to do. I'm not. So submission is a very powerful position to be in. So yeah, so we're not passive, we're submissive. So if you give me a scenario, you want me to write a good scenario on it, and you give me some vitals that don't match the physical description, I'm not just going to be passive about it. I also have an assignment to do and a time I need to do it by. So I'm going to make changes. I'm going to make changes that help me complete this assignment. Yeah. No passivity. Direct yourself. Okay. On scene, patient is assessed on scene with vitals and left wrist bandaged. Patient is placed on a transportation hold by PD and walks to rig. Patient is, oh, hey, look at that. I've already written down here. Patient is secured to stretcher and transported to, let's say, no, Regions is horrible. St. John's ER. Patient rests calmly and remains cooperative. Patient's wrist is still controlled upon arrival. Oh, and vitals monitored. Vitals monitored. Upon arrival, patient is transferred to ER, let's say room 14, ER 14 in care, to ER RN. So with this, a big aspect of it is the patient needs to be cooperative. That's what we're going to put. The patient's going to be put on a transport hold because they've threatened to hurt themselves, and we can't have that. Or not threatened, they have hurt themselves. And I always say how the patient does, right? So there we go. So there is a SOAP narrative and like 3 good rants. It's not bad. That's not bad for one video. All right, let me know if you guys need any help with this one. And that's all I got.